आज यदि भी आवाज इतनी तो नहीं जाती होगी कि इसकी आवाज क्यों पहले क्यों बोल रही? आप अनम्यूट कर दिया आपने? बिस्मिल्लाहिर्रहमानिर्रहीम। रब्बि इश्रह ली सदरी व यस्सिर ली अमरी वहलुल उक़दतम मिन लिसानी यफ़क़हू क़ौली। Well, yesterday we talked about the non-infectious hepatitis and causes started with the autoimmune drug-induced other toxins which can induce hepatitis and alcoholic hepatitis. Well, when we talk about alcoholism, obviously you must know the definition that alcoholism means chronic alcoholism. It's not only one drink or a day or 2 days or 5 days. So people, they are used to drink alcohol, and that depends. Well, the effect of alcohol intake depends, I told you last day, on many things. Number one is what type of beverage or wine or alcohol a person is consuming or has got the habit of using. And second is the quantity, how much quantity one is taking, maybe one thing, or the heavy drinker or a moderate drinker. Duration, since how long one is drinking. It's almost the same as with the smoking causes this CA lung or bronchogenic carcinoma. So duration, quantity, and so all those changes in the hepatocytes, that depends on that. But one thing is, I told you yesterday, the three things as a pattern which can happen. Initially, there is accumulation of fat droplets, water, and later on, the toxic effects. Why the toxicity is because the aldehyde or alcohols, when they join with the proteins, they make a molecule which has got the tendency to release oxygen radicals. And those oxygen radicals are toxic to the cells. And here we are talking about the hepatocytes. So hepatocellular toxicity is because of the oxygen radicals released because of the joining of alcohol with the proteins. Well, if moving on to that, I just repeated this only for the reason that the other, today's topic is in fact metabolic liver disease. We're using the word metabolic because the disease of liver, which is because of certain metabolites. So when they are trapped into the hepatocytes, one is the fatty liver, or as fatty liver is steatosis, is a condition in which steo means is related to bile, bilirubin, but steatosis, that which is the first stage in alcoholic hepatitis. So that is almost the same as that of fatty liver. Or you vice versa can say that one of the cause of fatty liver is the consumption of alcohol. There are other causes. That doesn't mean that those who do not take alcohol, they cannot develop fatty liver. Fatty liver can be developed in cases in people or in persons who are not consuming alcohol. So non-alcoholic fatty liver, alcoholic fatty liver, so fatty liver causes, and though you can improve that. So that's the reason I'm just repeating the alcoholic hepatitis, as steatosis or fatty liver is the first step in the development of alcoholic hepatitis. That steatosis can develop into hepatitis, you call alcoholic hepatitis, and then onwards, if the person does not leave the habit of drinking alcohol, there are chances, very high chances, that the person may develop cirrhosis, and cirrhosis can transform into hepatocellular carcinoma. So this is one of the reasons I started with, again, the alcoholic liver disease. So you can say the fatty liver is also, the other metabolic liver disorders are hemochromatosis, means a condition, chromo is the word from pigment, a condition in which a pigment is entrapped into the hepatocytes. Which pigment? Heme. Heme, in fact, is containing iron. So the word used is hemochromatosis. In fact, this is iron pigment which is deposited into the hepatocytes, and the disease is called hemochromatosis. Well, other one is Wilson disease, that is copper. Another is Alpha1 Antitrypsin, a deficiency in this. The deficiency of protein is there, but what happens is we will talk about it later. So today's topic will be more metabolic liver diseases and all these four. So moving on to that, the fatty liver, as I showed, this is the same diagram which I showed you last day, that normal level of alcohol consumption is there, can develop into steatosis or directly cirrhosis, or steatosis first stage, then developing into cirrhosis, and both then can, the patient may develop, this is hepatitis, the patient may develop cirrhosis, and then this carcinoma, hepatocellular carcinoma. So HCC you call it usually. The same is true over here. So if you just focus over here, what happens is that the changes are there, the organ becomes enlarged. Why the organ become enlarged? Obviously, in every cell, there is accumulation of fat and water and proteins. The cell is ballooned, or it becomes enlarged. And when one cell is enlarged, obviously, it affects the whole organ, and it's hepatomegaly, you can call it. The organ is enlarged, you call it hepatomegaly. It's has got a yellowish tinge of color because of fat is yellow. And then this change is reversible. That means the same is true for alcohol. What are the causes of fatty change? Let's talk about that first. The causes, obviously, all of you know, nutritional causes are the more important, because the diet which you take is usually converted into glucose in the liver, and excess glucose is converted into glycogen for deposition into different places, and it is converted into triglycerides. Some synthesis of cholesterol is also there in the liver. So the extra glucose, which is not utilized, is converted into triglyceride in the liver, and that triglyceride is deposited in the adipose tissues of your body. Obesity, central obesity, or so the places where fat is deposited, you call adipose tissues. So this is obviously, if your nutritional habits are, and the habits of exercise are not there, so consumption is not there, intake is more, what will happen? There will be accumulation of fat. और फैट जब इकट्ठी हो जाती है तो वो जहाँ एडिपोज टिश्यू के साथ साथ लिवर में भी, और बल्कि हर ऑर्गन में भी, at times in the organ or sometimes outside the organ. So it is deposited. So the same is here. Causes of fatty change in liver is, obviously, there are two causes. One is there is extra synthesis of fat, and that is not released. Secondly, either synthesis is more, or if synthesis is normal, it is not released into circulation because of the receptor deficiencies. So that we are not going into that biochemistry, but obviously fatty change in liver is usually seen in patient who has got the habit of taking more fat and more nutrition. not necessarily fat only, even if you take extra carbohydrates, finally that gets converted into fat because the surplus glucose is stored as fat. So one thing is extra synthesis or extra intake, so nutritional cause you can say. And the second is that the hepatocyte do not release, or there is no metabolism, or there are some problems in which the triglyceride is not, broken down into cholesterol and fatty acids, and is not released. So it is retained in the hepatocytes. So these are the two causes. The same is for alcohol. Alcohol also leads to malnutrition, and because of malnutrition. So steatosis or fatty change or first stage of alcoholic liver disease, they are the same almost, but the cause may be a little different, obviously. In that you are taking alcohol, and the other you are taking more fat, or you are have the habit of taking more diet, more than the requirement. Organ is grossly, when you talk, the organ is enlarged and is yellow in color, and this change is reversible. When you take the slide, you will find the lipid droplets are accumulated. There is microvascular globules or macrovascular. Hepatocytes, they are ballooned, they are enlarged. Ballooning means they are enlarged. Why they are enlarged? They are enlarged because of the deposition of or accumulation of fat, water, and proteins. Obviously, when this fat will lead to injury to hepatocytes, there will be neutrophilic infiltrate, or you can say inflammatory processes there. This change is reversible. If you stop taking more fat or more diet, the change is reversible. The person will start surviving from the endogenous fat instead of exogenous. तो जब आप बाहर से डाइट नहीं लेंगे तो अंदर की फैट जो है वो पिघलना शुरू हो गया आपको उससे. So the change is, you can call it reversible. Same is true for alcoholism. If you stop taking alcohol, the change is reversible. So the person does not go into hepatitis or cirrhosis or later. But if you keep on taking it for a very, very long time, and if you drink heavy alcohol, obviously you have to face the music. So this is because the microscopic picture and the gross appearance of fatty liver. It's a very common slide which is shown in OSPs. And this is the slide usually. You can see these vacuoles, these vacuolated hepatocytes. These vacuoles are because water and fat, water is not stained. Fat is stained with special stains. So with H and E stain may usually the small vacuoles, large vacuoles, microglobules, macroglobules, whatever you call it, neutrophilic, some neutrophilic infiltrate. So you can label it as a slide of fatty liver. Well, the second disease which we were talking about, and that is hemochromatosis. So amongst the metabolic liver diseases, I have already told you that it's a condition in which a pigment, that is the iron pigment, is entrapped, or you can say is deposited in the, I'm using the word entrapped and deposited, although these are two different words. Entrapped means jo aa gayi hai wo phas gaya. And deposited means if there is iron overload, obviously it will be deposited in different organs. And one of the organs where there is deposition of iron, that is liver. Isme, what can be the etiology? So by definition, hemochromatosis is a condition in which the iron is deposited, or you can say there is iron present in the hepatocytes. As this iron is toxic, it can lead to cirrhosis. And the cirrhosis, which is due to iron overload, you call it pigment cirrhosis. So disease is the same. So this is inherited disease. So amongst the metabolic disorders, the fatty liver is acquired. That means it is because of your habits. Habits means you take more food and you don't consume them. There is no exercise. The person has got the sedentary habits. तो कंजम्पशन हो नहीं रही, इनटेक ज्यादा है उसकी वजह से it's called an acquired disease. The other rest three are hemochromatosis, Wilson's, or alpha-1 antitrypsin deficiency. They are inherited. So there is some element of genetics. The chromosome 6 is in fact is the site where the one of the gene responsible, that is this hemochromatosis, F is for iron. This HFE gene on chromosome 6 is responsible for the absorption of iron. So remember, HFE, I'm repeating, this gene present on chromosome 6 is responsible for absorption of iron. So how does it occur? And that is, in fact, transferrin is circulating in blood. So what is transferrin? Transferrin is a protein, is a glycoprotein, in fact, which binds with iron and circulates in the blood and transport that iron to different organs like bone marrow for synthesis of blood, and liver, and many other organs for usage. But this circulating transferrin written over here, you can see from this diagram that it is the beta-2 macroglobulin. So this word is only telling you that if you perform an electrophoresis, it occupies the place of beta-2. I showed you the diagram of electrophoresis. There is albumin, alpha-1, alpha-2, beta-1, beta-2, and then gamma globulin. So this is the graph of electrophoretic protein electrophoresis. So it's the beta-2 place where this iron protein is, or you can call that is the site of transferrin on electrophoresis. So it's just by the way I'm explaining you. Otherwise, this macroglobulin, or you call protein, along with this receptors. So here you can see that this is circulating in plasma. We are talking about the etiology of hemochromatosis. Rather, we should say, I forgot to tell you that there are two types. One is primary hemochromatosis. The other is secondary. Primary is genetic related, and secondary, it is acquired. We'll talk about that a little later when genetics may. I told you that it is the HFE gene on chromosome 6, which is responsible, and the responsibility or the function, you can call it, of HPE is related to absorption of iron. But in plasma, once what happens is, after absorption, what happens is it joins with this blue color is protein, and this red color is iron. So iron joining with transferrin, this is how it circulates in the plasma or blood. This molecule consisting of, or you call transferrin bind iron, is taken to hepatocytes, and where there are receptors for transferrin, and those receptors are named as transferrin receptors. This molecule joins with the receptor, and HFE again here also is responsible for this endocytosis, or you call intake of this circulating transferrin, which is containing iron, into the hepatocytes. So hepatocytes में जाके ये release हो जाता है, and this is released in the form of ferrous. Well, most of the time, I'm sure I just want this, but that is physiology. You must recall the word. One is ferritin, the other is transferrin. So what is the difference between transferrin and ferritin? If all of you are unmute, anyone who can answer me, what is the difference between transferrin or ferritin? So are you on the line or? Okay, Aniba, are you there? Nur Fatma? Mariam Bilal. Are you there, or you are not listening, or you don't have the answer? Okay, forget it. Let me tell you, ferritin, in fact, and transferrin. Transferrin is the glycoprotein which binds with the iron molecule and takes it to the other organs. So you can say the transport function of iron metabolism is given to transferrin. Whereas ferritin levels, in fact, that reflects the iron stores in the body. If you ask a person for ferritin level analysis from the laboratory, if the level of ferritin is low, that will reflect that the iron stores in the body, wherever they are stored, is less. So ferritin जब करवाया तब जाता है जब हम ये जानना चाहें. एक test है, you ask for assay of iron level in the body. The other is ferritin level. Ferritin level reflects the iron stores in the body. Transferrin levels shows that how much protein is there, free iron is there, and bound iron is there. So iron in plasma circulates less as in free form, more with after binding with transferrin. So one is a binding protein, which is a transport protein. It takes iron from one place to other place. Ferritin is the stored iron. So this is the difference. Bharal, what happens is this circulating transferrin form after absorption is taken to hepatocytes. Again, here HPE helps it. This binds to the receptor, and this gene, it takes this iron into the cells, into the plasma, where it is the ferrous form is released. I'm sure you know ferrous and ferric. There are two valencies for ferrous and three for ferric. But ferric is a toxic element more, in fact. Ferrous is not. This joins with this iron regulating proteins. These are the iron regulating proteins. So they regulate the iron metabolism. So उसका low level होना, ज़्यादा होना are dependent on these proteins. So they either go into the nucleus and is stored over there, or stored in the this cytoplasm, or it is released and into the again circulation. So this is the etiology, and so if the mechanism, if this is disturbed, so what happens is endocytosis is there, storage is there, but it is not released into circulation. So what happens? You can call it the iron is entrapped into hepatocytes, and the condition develop. As I told you, it is toxic. It can cause cell injury because of the release of oxygen radicals. So what happens is there is injury to the hepatocytes, and the patient may develop hepatitis. Such sort of a disease in which HFE gene is responsible, you call it primary hemochromatosis. So this is absorption. This is the place where this. I'm sorry, it's secondary. Instead of writing it over here, it's placed over here. But hemochromatosis, one is genetic, the other is acquired. The genetic we already talked about. That is more so related to absorption. And if there is more absorption, if there is more iron intake, more absorption, and more entrapping into the hepatocytes, so that pigment can cause injury to the hepatocytes and lead to hepatitis, which is hemochromatosis. Secondary means the problem is not genetic. Either there is ingestion of more iron. People, they have got the habit of my hemoglobin is low, so without any advice or without an investigation whether they have got low iron, they keep on taking those iron tablets, and they may have iron overload. And second is you are taking iron, like if you are, as we already talked. So hemochromatosis, those who are taking beer, they have got the chances to develop alcoholic hepatitis, as well as beer is having more concentration or more contents of iron. So they can also have hemochromatosis. The third thing is transfusion, multiple transfusion. So transfusion means red cells. Obviously, when there are multiple transfusion, the red cell life is different. So if the more red cells are broken down, more heme is released and more iron is released. And that iron has to be regulated. If it is not regulated, it will be deposited somewhere. So secondary causes means either iron is more, or iron containing diet or iron containing beverages are taken more, or multiple transfusion type of things. They can also lead to hemochromatosis. So there is, because this is because of high iron intake, and you call it secondary hemochromatosis. The other cause of secondary hemochromatosis is ineffective erythropoiesis or hemolytic anemias like sideroblastic anemias, thalassemia major, in which there is more breakdown of RBCs. And when there is more breakdown of RBCs, obviously you can follow the sequence of events. What can happen is that there is more release of heme and more release of iron. And when iron overload is there, obviously either it will be excreted or it will be deposited. So secondary to ineffective erythropoiesis, different type of anemias, and the example is sideroblastic anemia, thalassemia major, in which again there is more breakdown of iron. In cases of sometimes accidents when there are large hematomas inside or large bleeding, that can also have some deposition of iron in places, but usually it does not take to cirrhosis, and the patient, as he recovers from that trauma or injury or accident, usually it reverts back. Or you can say that iron is utilized because iron is the requirement for synthesis of hemoglobin. So the third we already talked about, that is secondary to liver disease. So if there is any problem in the liver, there are chances. Cirrhosis है या portocavit shunt, तो ज़्यादा shunt की वजह से more blood is there. Obviously, there are chances कि वो iron वहाँ का वहीं trap ho jaye. So these are the causes of secondary hemochromatosis. So after talking about the causes, clinically the patient usually has a hepatory. You can see in this diagram that multiple organs are involved: liver, spleen. These are the RBCs broken down and they go to the spleen. Same is this iron stores in the liver. So ये plasma में जब आते हैं, either they are excreted through intestine or through this urine. But bones and joints, liver, spleen, joints, synovial membrane, so skin, even testicles, these are the places where this iron, but their skin and testicles, they are less common sites. More commonly they go to bones, they go to liver, and they go to spleen. These are the more common, and heart. So cardiac involvement and joint involvement is the second. The important one are liver, spleen, and bones. The second is the cardiac or heart and the joint and synovial membranes. The features are usually very vague. It's more commonly symptomatology does not more help in patients of hemochromatosis. It's only when you suspect and then you send the patient for laboratory investigation. Laboratory tests which can be done, that is serum iron level. Normally, it is only 20 micromole per liter. MIC means micromole per liter, and but in hemochromatosis, you just see the difference. It's almost 7 to 8 times more. So the concentration of iron in plasma is 250, approximately 200 to 250. This microgram, or that was this is wrongly written over here. Again, it's micromole. So 20 micromole per liter is the normal concentration of iron in the blood. but it is almost 7 to 8 times more or 6 to 8 times more. And obviously such an overload of iron, if seen, there are chances of hemochromatosis. उससे कम अगर हो तो वो iron usually utilize हो जाता है for synthesis of hemoglobin, and otherwise, but if the load is so high, sorry, so you get deposited. तो दूसरी बात ये है कि secondly, iron is bound to, I told you, in the plasma, it's the transferrin. So how much protein is saturated and how much is free? So transferrin saturation, if iron is more, saturation will be more. I'm sorry. So if iron is more, transferrin saturation is more. So normally this iron binding capacity is 50 to 60%. Say bhi badh jata. So you can analyze iron. You can go for iron binding capacity. Say language में TIBC कहते हैं, total iron binding capacity. But that's usually it's 25 to 30%. But if it becomes double, so you can say that there was an iron load जिसकी वजह से जो protein है उसकी binding ज़्यादा हो गई है. ठीक. And the third thing is I told you the iron, ferritin. So this provides you an indirect evidence. If the iron stores are more, those organs which are involved in the storage of iron, as I've already told you, that the liver, spleen, bone, and synovial membrane, and less commonly heart and others. So, जिन organs में ये deposit होता है, if the stores are more, तो stores कब होते हैं ज़्यादा? जब आपके पास कोई चीज़ surplus होती है. So one thing is directly serum iron is increased, iron binding capacity is reduced. Capacity is reduced, TIBC, but transferrin saturation is. Why I said the capacity is low? Because if there are less proteins, so the capacity of transferrin becomes low. It has got less chances to bind more iron. Already it is 50 to 60%. So if it becomes fully saturated, problem will arise. तो saturation जब ज़्यादा होती है, obviously इसका मतलब है कि protein की quantity कम हो जाती है. When you say TIBC, total iron binding capacity becomes low. Transferrin is, the protein is more saturated. So it has got, the level of transferrin is less, iron binding will be, there are less chances, but saturation is more. So transferrin saturation को आप ऐसे कर सकते हैं, ferritin level indirectly evidence है. इसमें भी you can say कि if it is more than 1000 nanogram per milliliter, ng is nanogram. That also indicates that there are chances that the patient will start developing cirrhosis or cirrhosis secondary to hemochromatosis. The fourth investigation is you can go for this hepatic iron content. Well, it's very difficult. But and fifth is hepatic iron index. So HII index means how much iron weight and how much is the weight of total weight of liver. So proportionately total weight of liver may agar iron is you know the molecular weight, it's a high molecular weight iron, obviously. So if it is more than 1.9 indexes, so that also is an indicator. So these are the indicators of that the chances of cirrhosis can be there. एक तो diagnosis हो जाती है इससे कि hemochromatosis है, दूसरे chances of developing hemochromatosis. The last thing is you can go for fine needle aspiration, cytology or biopsy. So what do? Is you insert a needle and you take the specimen and you stain it. This is the color, or but here this is an H and E stain. If you perform Prussian blue stain, so you will find that the whole side will be having a lot of iron. So iron is stained with the specific stain for iron is Prussian. So normal HE stain पे ऐसा होता है, and the more these are all hepatocytes within filtrates and cells, inflammatory cells, but these colors, these are for iron. लेकिन अगर यही चीज हम HNE पे स्टेन करें, Prussian blue स्टेन करें, तो you will find कि ये ना सिर्फ ऐसे ये आयरन है, बल्कि ये, और you will find many more Prussian blue stained iron contents in this slide. So moving on to next is the Wilson's disease. It's as the previous was related to iron, this is related to copper. So Wilson disease is after the name of that scientist. This is the 2.5 milligrams per day is taken normally in the diet. The copper is taken in the diet. And copper is again of two forms, cuprous and cupric. Cupric is more toxic. In GIT, it is absorbed, and in the plasma, as it was transferred, here the word is celluloplasmin. So this is the binding protein. 95% is bound to this protein, copper binding protein, which you call celluloplasmin, and 5% is bound to albumin. So very small, minute, less than even 0.1% is found in the free form. Immediately, either it binds to albumin or celluloplasmin. This copper, which is bound to this binding protein, celluloplasmin, it goes to liver, and after metabolism, it re-enters into plasma. So this albumin bound is also, it goes to liver, and again it is reverted back to either plasma or to GIT for excretion or to kidney for excretion. So this is the metabolism of carbon. So obviously, so what can happen? Etiology अगर आप सोचें तो विल्सन डिजीज में क्या होगा? इनटेक ज्यादा हो, या यहाँ पे लिवर में ट्रैप हो जाए, या एक्सक्रीशन कम हो जाए. So either absorption from GIT is increased, or तो ये तो these are the steps. After absorption, it's transported to liver, and then it is taken up by the liver hepatocyte. अब उसके बाद celluloplasmin formation पे depend करता है. अगर celluloplasmin कम हो तो obviously more copper will be free form में will be delivered to liver, और जब वो free form deliver होगी, that is toxic. So celluloplasmin secretion into plasma पे depend करती है Wilson's disease and uptake of copper excretion भी अगर कम हो जाए because of some obstructive problem in the biliary tract, so the copper remains in the liver, and that is toxic. So if the excretion is less through bile into the GIT or into the kidney, so what happens is more copper is retained in the liver, and that leads to Wilson disease. So metabolism में GIT से होके plasma से होते हुए liver में, and then excretion. So you can think only this is the place. Either this is very small in quantity, so free copper जब enter होते हैं, that is toxic, and that too I told you cupric form. And secondly, ये excretion अगर कम हो जाए either in the kidney or bile, more commonly in the stool, so copper remains or retained in the liver, and then you call it Wilson disease. So hepatitis can be because of the toxicity of copper. So copper is injurious to hepatocytes, so it can lead to hepatitis. So this is one cause of hepatitis. Metabolic hepatitis is Wilson's disease. Wilson disease के clinical features में ज़्यादा जाने के बजाय, one of the very important feature is that the Kayser-Fisher ring is found. This ring is found around the retina. आम तौर पे इसी से diagnosis ज़्यादा होती है. Otherwise, copper के कोई clinical features, mostly the patient is asymptomatic, आपको पता नहीं चलते. Bharal, if an ophthalmologist with an ophthalmoscope or his expertise, direct examination, if I thinks that this is a ring, तो वो फिर ये test करवा सकता है. That is serum copper level, obviously number one. Number two, celluloplasmin levels, जो बाइंडिंग प्रोटीन लेवल है. कॉपर ज्यादा होगी, सेलुलोप्लाज्मिन लेवल कम हो जाएंगे. तो इसीलिए ये लिखा हुआ है less than 20. You can just think it's not a very it's a game of that you learn by heart or rata lagaye. So obviously if the serum copper level is high, so obviously the ceruloplasmin level will be low. ये binding कम हो जाएगी और जो protein कम रह जाएंगी. So either you ask the patient for assay of serum copper level, or if the facility of copper level is not available, you can ask for the levels of ceruloplasmin level. But remember, in Wilson's disease, either the copper level is high or naturally the binding protein level is low. अब ये इसी तरह urinary copper level will be high, and same is true कि अगर आपको if you get a chance to go for hepatic copper, there are certain laboratories, not in Pakistan, but in abroad, very high sophisticated laboratories, they can form the hepatic content level of copper. So that is also moved. तो क्या मकसद ये है कि कॉपर लेवल ज्यादा होगा या यूरिन में कॉपर ज्यादा होगी या स्टूल में कॉपर ज्यादा होगी या लिवर में कॉपर ज्यादा होगी और इनडायरेक्टली या सेलुलोप्लाज्म लेवल कम होंगे, सो दैट यू कैन थिंक ऑफ Wilson's disease. This is for diagnosis. Alpha1 antitrypsin deficiency, very interesting thing, that alpha-1 antitrypsin, AAT, it's a protein produced in the liver, one thing. Secondly, this protein from liver circulates in through blood and goes to lungs. And what is the function? The function is that the main function of AAT is to protect lungs from the inflammation. So, जैसे कोरोना inflammation lung cause करता है, alpha-1 antitrypsin deficiency से भी lungs में infection हो जाए. और अगर वो ऑलरेडी पेशेंट टोबैको स्मोकर है तो ज्यादा चांस है कि जल्दी. सो दिस डेफिशिएंसी का ताल्लुक इज रिलेटेड विद वन और इफ यू टॉक अबाउट द इटियोलॉजी, ये ऐसा डिसऑर्डर है कि वन जीन फ्रॉम वन पार्टनर इज अफेक्टेड, तो तब भी डिजीज होगी और दोनों की तरफ से जाएगी तो ज्यादा सीवियर डिजीज होगी. सो इट्स अ डिसऑर्डर एसोसिएटेड विद द premature onset of chronic obstructive pulmonary disease. So हम बात लिवर की कर रहे हैं, लेकिन याद रखें कि how liver is involved in this alpha-1 antitrypsin deficiency. काम तो इसका ये है कि synthesize जरूर liver करता है and it then releases it into liver, और वहां से जो है वो lungs को protect करता है from this fighting agents of antimicrobial infectious agents. तो lungs को बचाता है for inflammation. लेकिन इसकी डेफिशिएंसी से मुराद यही है कि सर्कुलेशन में डेफिशिएंट होता है. वजह सिंथेसिस कहाँ हो रही है? लिवर में. अब वो जो सिंथेसाइज कर रहा है वो एबनॉर्मल टाइप ऑफ प्रोटीन अगर सिंथेसाइज करे तो वो बेकार है, किसी काम की प्रोटीन नहीं है. सो देन alpha-1 antitrypsin deficiency in the blood is there, but in the liver this is an abnormal type of protein जो सिंथेसाइज हुई है, जो रिलीज नहीं होती और ट्रैप हो जाती है लिवर में. तो उस वजह से when a person has alpha antitrypsin deficiency, what happens is कि लिवर में एक abnormal protein जो बनती है उसकी वजह से. So it's a genetic problem. So already I have shown you one slide that this is a genetic problem. Wilson's disease is a genetic problem. But hemochromatosis में कुछ secondary causes भी हैं. So that protein is then trapped into the liver and then it is toxic. It leads to fatty liver and then onward the same pattern, that fatty liver, then hepatitis, then cirrhosis and hepatocellular carcinoma, like that. So isme, the last minute is that how do you diagnose that? You diagnose it with number one, a blood test, and number two, the AAT deficiency genes or PCR type, you can say chromosomal analysis, and then you can also go for liver biopsy. Treatment iska koi cure nahi hai except counseling, or one help can be taken for the diagnosis of AAT deficiency is that you go for liver FNA or FNA cytology, fine needle aspiration or biopsy. Biopsy mein what you will see that AAT protein or abnormal type of unfolded protein is and trapped into the liver cells as inclusion bodies. You can very well appreciate it in this slide that this arrow and this arrow. So these are you can appreciate it that this is the color and this. This is very different from the normal hepatocytes. So this is also very a diagnostic that inclusion bodies which take this pinkish, very clear round in the hepatocyte, they are AAT proteins. They are different from the Mallory bodies, remember. So this was all about this alpha-1. So we talked about today the metabolic liver hepatitis or liver disease. Thank you very much.